Good afternoon to everyone. A big thank to Nick and also to STARS to organize this meeting. So I've been asked to share what an autonomic neurologist do and when to refer to a tertiary referral center. So I will briefly just describe our center at the National Hospital for Neurosurgery, what we provide, what is our approach to autonomic disorder, and when to refer. So this is our center. We're based at second floor of the Queen Wing in Queen Square, and we work in a multidisciplinary team. There are 4 autonomic consultants in the unit, 4 specialist nurses, 14 clinical scientists, and 4 between NHS-funded clinical fellow and researcher. In terms of cohort of our patient, at the center we see usually 3,000 patients per year, and this is our cohort. So it does change over time because it depends obviously the referral to the center. But 40% will be patients with intermittent autonomic disorder, between 25 and 30% are patients with a neurodegenerative disorder, so with a structural autonomic disease, and 15% are patients with peripheral neuropathy, and then there are more rare disease. In terms of who does refer to the unit, for the nature of the autonomic neurology is a multisystemic disease majority of the time, so patients obviously are seen by several different specialists. And we did an audit twice. We did an audit in 2013 and the same audit a year ago actually. And we are getting better in recognizing, I guess, worldwide autonomic disorder. However, it's still not uncommon than patient, there is a delay in diagnosis. So there is a cohort of patients that still are referred to a specialist center, or they do get the proper diagnosis with a delay between 6 and 7 years. And so it means then definitely we need a major effort to improve. So in terms of what we provide, so we do have patient care pathway for different disease, but just to give an overview of what is the patient journey in our center, the patient is seen by one of our consultants. There are 15 weekly autonomic clinics, 2 weekly telephone clinics for patients that they are from far and they are not able to attend the National Hospital, and we do have also an adolescent service. Then we did pilot in 2014, and now is open for referral between 16 and 18-year-old. In terms of diagnostic, the autonomic investigation, it does occur either as an inpatient, daycare, or outpatient. We have a 4 autonomic cardiovascular lab and 1 thermoregulatory chamber. And in terms of management, all the patients that they are seen by the consultant and they go through the testing, they are discussed in a multidisciplinary team meeting with our specialist nurse and with our clinical scientists, but also in discussion with our neurologist within Queen Square. So for the purpose of the talk today, I will be concentrated more on POTS and vasovagal syncope. So in this particular patient group, if the diagnosis is confirmed, we do have management clinic dedicated, which are group clinic dedicated to patients with syncope and POTS, and the main aim is about education. We have a tailored exercise program, and we provide inpatient autonomic rehabilitation. So what does happen during the consultation? What an autonomic consultant would do? So the clinical history is still the main tool in terms of making the right diagnosis. So it's very important to have a systematic review of all the autonomic domains. So we have learned and we have heard many times today that obviously cardiovascular is one of the major domains investigated, but autonomic dysfunction, it does not just affect cardiovascular function. In clinic, it's quite likely to be able to answer the question of whether we are in the chapter of structural disorder, so autonomic failure, or we are dealing with a patient with intermittent paroxysmal dysfunction. And definitely we don't want to miss any reversible condition. Another important question to answer is whether the autonomic dysfunction is a localized dysfunction or is a more widespread involvement of the autonomic nervous system, what is the time course, and this should not be neglected, whether the symptomatology is the results of a iatrogenic nature, so it's the results of the medication the patient is on. In terms of the diagnostic, autonomic testing are very useful in answer the question of whether or not there is an autonomic dysfunction, which branch of the autonomic nervous system does affect, what is the degree of autonomic dysfunction, and quite often testing are also quite useful in terms of guidance on a most appropriate management. So in our unit, we're mainly focused on evaluating cardiovascular, autonomic and thermoregulation. However, we are very fortunate at the National Hospital. We work very close with the uroneurology unit, with Dr. Panica, with the neurogastroenterology unit, with Dr. Emmanuel, and we have Mr. Bremner, who is a neurophthalmologist with a long-standing experience in autonomic disorder. So the head-up tilt we had on several talks, whether or not is of help. So definitely it does help phenotyping the intermittent disorder, but the head-up tilt also we should not miss then actually frequent syncope in a patient with a normal heart. They are not all vasovagal in nature. Yeah? So definitely we don't want to miss a structural autonomic disorder with orthostatic hypotension. We perform as a baseline assessment in our unit a tiltable test with a cluster of other autonomic investigation. I won't go through all the autonomic testing. Professor Mellobo will go through the investigation of the autonomic nervous system, but this is just to show them Valsalva, deep breathing, an ambulatory blood pressure profile, and catecholamines. They give quite a lot of insight in terms of phenotyping the patient, quantify the degree of autonomic dysfunction. In select a patient, if you want to gain insight into what's the physiology with the exercise, we perform a supine exercise, and the main aim is really assessing whether or not exercise does induce hypotension. We discussed just earlier on, obviously there is a reduction in blood pressure, which it might be quite a significant impairment in patients with autonomic failure. Also, patients with POTS, the exercise can exacerbate or mask the postural tachycardia. It's quite a useful test to assess the exercise tolerance. We learned that exercise is a key management plan in patients with POTS, and we use the exercise also to monitor response to autonomic rehab. In terms of the liquid meal challenge test, beside the postprandial hypotension, which is key in patients with autonomic failure, food can also exacerbate symptoms in POTS because of the splanchnic hyperemia, and this is on the upper panel. Is just an example of a patient that was not that tachycardic before meal, but there was definitely an unmasking of POTS post-meal. And we use the liquid meal challenge test also to assess the response to the octreotide. At the unit also we perform pseudomotor thermoregulatory investigation, looking at quantitative postganglionic function with what we call the dynamic sweat test. So you stimulate the skin with either pilocarpine or acetylcholine, and this is what you would see in a normal control. These are all drops of sweating, and this is what is a likely scenario in a patient with a neuropathic phenotype, which is not just about the classical autonomic neuropathy, but you can see this phenotype in patients with a neuropathic POTS. A thermoregulatory sweat test, we do have a thermoregulatory chamber, and the combination of the two tests is quite useful in localizing the dysfunction of the autonomic nervous system, whether it's a central or is a more postganglionic disorder. And we use a TST, is quite an important marker when it comes to patients with autoimmune pathology, which the pseudomotor is, the majority of patients is affected, and you can monitor the response to treatment. So when to refer? So I thought then to answer this question, maybe we could go through some of the cases. So it's a case approach from our MDT, and again, I did focus on patients, and they were referred to the center with a working diagnosis of POTS and vasovagal syncope. So case 1, this is the original referral, so 56-year-old who appeared to have vasovagal syncope but has really not responded to any of the treatment over the years and continued to have 6 episodes per day. She has also been labeled as having no epileptic seizure. That was quite distressing for the patient, so the label itself. At the autonomic review was clear that the patient was experiencing 2 different episodes, which is not uncommon. So the patient had an episode that was very well known to the patient itself and was not really bothering the patient. So since the age of 2, she was having this episode all her life and very vasovagal in nature, with a frequency of 4 times per year. Only in the last 10 years, the patient did develop, following an head injury, fall, a frequency of 4 to 6 times a day, lasting for seconds or up to half a minute. Some of these episodes were described with some prodromal, and the patient did also describe then pain, and heat stress was one of the possible triggers. So there were 2 different syncopal episodes. So this is the head up tilt of this patient. So this is the start of the tilt. Blood pressure was quite well, with some fluctuation, as you would see in patients with intermittent disorder. At this particular time of the tilt, the patient had a sudden slump to the right, and she did recover spontaneously. So, and when we did ask the patient, this was the typical episode she was experiencing in the last 10 years. So no hemodynamic change in this case. Later on, you can see there is another drop, very likely to be pre-syncopal. Patient obviously didn't lose consciousness, but at the end of the tilt, a very characteristic drop in blood pressure and heart rate, and this the patient did recognize. Then actually they had the historical collapse that she had since the childhood. So this is just to make the point that in patients with the longest standing vasovagal syncope, different pathology they can coexist. So it's very likely that she was having a dissociative element, pre-syncopal episode on top of the very well-established vasovagal syncope. And addressing both is what obviously does help managing the symptomatology. Case 2, 50-year-old with a 2 years history of funny turns. That was the referral from the local physician. Feels like she needs to sit, tunnel vision, pressure in the head toward here, not responding to no pharmacological measure in combination with fluidocortisone. At the autonomic review, definitely the symptoms that were induced by the orthostasis with a postural change. She also does report coxango pain when upright. She has never fainted or fall over. Constant tinnitus, and the voice was now croaky. Nocturia with possibly a frequency every hour and night and during the daytime. Constipation with some episode of diarrhea, some shakiness. She described and she feels ill if she's too hot. Abdominal pain with a big meal. She's generally very tired, and she screams and thrashes out in the sleep. Dreams can be quite vivid. So the important point here is really systematically addressing all the autonomic domain. So the patient, the problem here was not just about the orthostatic intolerance. There are definitely other autonomic domains that they are involved. Gut, bladder, a possible REM behavior disorder. So the patient had a label of vasovagal syncope, but on testing, and was started on fluidocortisone. Yeah? On testing, this is a very common history of orthostatic hypotension. These are our pressor stimuli. You can see that there was an abnormal Valsalva maneuver without an induced bradycardia, as you would expect in a normal control, and this is on standing. So this is one of the scenarios where actually normal heart, frequent syncope is not always vasovagal in nature, and this patient has been missed for a couple of years. So we did follow up the patient. I mean, this is a liquid meal challenge test on the same regime. She was still on fluidocortisone. So there is a drop during the digestion period. and a further exacerbation of the orthostatic hypotension on post-meal. This is the 24-hour blood pressure profile. As you can see, the patient, when he's supine, is very hypertensive. So definitely fluidocortisone is not a good candidate in this case. Yeah? We stopped the fluidocortisone. We did follow up the patient later on, and there is definitely less supine hypertension. There is a still consistent drop in blood pressure. This is the liquid milk challenge later on. Again, less of the supine hypertension, and which was confirmed also on 24-hour blood pressure profile. The tricky part then is this patient had 2 years, more than 2 years delay. These are the catecholamines, so you can see there is no increase of catecholamines when the patient is upright, which will give you some insight where the pathology is. So that was a case of autonomic failure, wrongly labeled as a vasovagal syncope for 2 to 3 years. In particular, we did follow up the patient. There was a patient with an alpha-synucleinopathy, then 4 years later developed multiple system atrophy. This patient, they can overlap in terms of presentation, and it's important to make an early diagnosis because prognosis is different and management also is different. Case 3, this is 44-year-old lady with autonomic dysfunction. Could you consider for autonomic dysfunction test? As a child, she had recurrent fainting spells and they were never investigated and got better on their own. She was referred to the epilepsy clinic with a recurrent episode of loss of awareness and convulsion, with the preceded symptoms of presbyacusis and phonophobia. And the events, they were quite rare, 1, 2 per year. She had all the investigation trying to exclude a diagnosis of epilepsy, which were all normal. And the consultant referring the patient to us as an expert in epilepsy, she was still concerned maybe there is an organic pathology here more than a non-epileptic seizure. At the autonomic review, I'm just reporting one of the episodes. It was a morning and she has been exercising in the gym. The gym was quite close to the home, so she decided to go back without taking a shower. On the way back, she was involved in a phone conversation, and the person she was speaking to recalled her saying, I have to go, I have to go, I have to go now. What it does follow is more tricky because obviously the patient doesn't have a good recall of the episode, but basically she had a collapse and she was admitted to the hospital. She never collapsed from lying, and there was an identified prodromal for her episode. So at the head up tilt, so this is the start of the tilt. You can see here some fluctuation as we have seen in the other patient, possibly presyncopal here, but a very classical. At the removal of the cannula, the patient had symptoms which she does describe typical of her episode with a loss of consciousness. So again, in this case, is about validating also the patient experience. I guess it's quite important for the patient to learn about the physiology and to show the patient the results of the test and having them an insight of what the cardiovascular physiology is. So it was not a dissociative element, and we discussed the case with the patient, and the patient did engage with no pharmacological measure. We haven't seen the patient as a follow-up yet. Case 4, this is a patient, 48-year-old lady with a probable POT syndrome, but also hypertension. She continues to be plagued by palpitation and dizzy spells. She was not syncopal. She was treated with a bisoprolol, ivabradine, and perindopril. A tiltable test was performed, and in keeping with a diagnosis of postural tachycardia syndrome, but the patient was still quite symptomatic. So the discussion with the patient with POTS is quite tricky. So I don't think we have a magic pill as we learned this morning, and it's not about addressing the hemodynamic changes in POTS. Is the matter of developing coping strategy. But in this particular case also, it's important to phenotype the patient a little bit more. Hypertension is not something you would see in a common scenario of patient with POTS unless it's a particular phenotype. So at the autonomic review, all the symptoms you would have described in a patient with POTS, orthostatic tachycardia and some chest pain, palpitation after food, dizziness and feeling off balance, severe headache, memory problem, gut dysfunction, an increased sweating, sleep disorder, no fainting episode, and exercise makes air palpitation worse, as well as feeling weak and shaky. So there are some red flags in this clinical history. So the postural tachycardia, the increased sweating, the hypertension. On testing, this is the Valsalva maneuver. So there is an exaggerated phase 4, as you would see in a particular phenotype of patient with POTS. And this is the head-up tilt, a lot of fluctuation in blood pressure, and definitely a very significant increase in heart rate. We did assess, so the patient was very exercise intolerant, and in this particular scenario, we assessed the exercise cardiovascular physiology, and you can see, so this is the standing. She was not able to perform the standing pre-exercise, she had to sit. Also, the exercise itself was very limited, and again, quite an increase in heart rate after. So this is a possible hyperadrenergic POTS. So patient in that case, then they could present with tachycardia associated with high blood pressure, increased sweating. Some patients, they will report headache, and it's important to recognize the phenotype, because patients, they respond to different treatment. So this patient was started on clonidine with quite a good response. I'm not saying that she's free of symptoms. She's still polysymptomatic, but she's coping better. And this is the blood pressure profile after clonidine, so definitely there is less evidence of high blood pressure. So phenotyping POTS, I mean, ideally in the future, what we want is a different management strategy for different POTS phenotype. At the moment, we are still calling POTS an umbrella of disorder, where actually there are different pathology involved. And here is just to make again the point, but something that we have heard in other talk. So POTS is not just complex because it's a different pathophysiology, but also because of several comorbidity. So I only did mention one, which is the joint mobility syndrome, because it's the one that quite often we see in our patient cohort, but there are other comorbidities that needs to be considered. And this is what makes the challenge clinically. Case 5, 60-year-old. Okay, so the last case, sorry, I'm taking a lot of time. So 60-year-old with diarrhea. She was first experiencing Christmas 2011, lack of energy, and lots of different involvement of the autonomic nervous system. She did develop other impairment, including orthostatic hypotension, Olmsted pupil, and she had a tiltable test locally, where again a classical vasodepressor vasovagal response with no heart rate changes. So this patient, 2011, she was with a label of vasovagal syncope. She was treated with midodrine and fludrocortisone with no really response. At the assessment, it was clear then that was not a vasovagal syncope, but actually the patient had a pupillary involvement. This is the shrink test. So she had a dry eyes and a compromised salivary production and some small fiber impairment. So unfortunately, the video doesn't work, but basically just trust me that there was an abnormal response to aproclonidine, which is an indicator of supersensitivity. Then you would see in patients and they are denervated. So fixed heart rate, abnormal Valsalva maneuver, and clear orthostatic hypotension. So again, this is a case with 7 years of delay in diagnosis in a disorder, then is a potential reversible disorder. So the ganglionic receptors were positive, and she had all the screening all the screening for the paraneoplastic, which were negative. This is a dynamic sweat test, so quite denervated, as you would see in patients with a ganglionopathy after some years of disease course. She was treated with plasma exchange with some improvement, and you can see some improvement in sweating as well. So just key point on the ganglionopathy, again another disorder that is definitely more recognized now, but can be missed and for many years, and this is a reversible condition which definitely we don't want to miss in patient. And it's an end of spectrum, so you can have patient with different presentation. Only the 50% of the patient they will have a positive antibody, but patient with a seronegative also they respond very well to immune treatment. So I don't think we have time to go to case 6, so sorry, I will skip this one. That was a case where actually the autonomic rehabilitation did improve the symptomatology. But just to summarize, so these are the possible scenarios then we can see clinically. So orthostatic hypotension, obviously, we have learned so much regarding vasovagal syncope. It's important to phenotype as much as we can when it comes to patients with postural tachycardia. Looking at other possibilities in terms of no epileptic attack or dissociative element, which they can coexist in a patient with established vasovagal syncope. There is an important role played by the autonomic rehab, which we have the fortune to be able to do as an inpatient. And some patients, they won't respond to first and second line treatment. And this is the scenario where we would use octreotide, which we don't use obviously as a first and second line treatment because it's quite invasive, but in some patients actually is the only candidate, then it does make a bit of improvement. So when to refer? So if syncope episodes are not controlled, or there is a diagnostic uncertainty or treatment failure, when the frequent syncope are related to a poor quality of life and risk of injury, and keeping in mind that a normal heart and syncope can be the manifestation of a structural autonomic disorder with neurogenic orthostatic hypotension. In terms of POTS, refer whether you are thinking that actually phenotyping the patient is important because it can guide different treatment. POTS, then they are not responsive to no pharmacological approach. They can be helped by a structured exercise program or different treatment strategy. And the most severe and debilitating symptoms not responding to pharmacological agent, they may need an autonomic rehabilitation program. Refer to the unit if you think that formal exercise testing could quantify the exercise intolerance, and definitely patients then they are suspected with splanchnic pooling and they are not responsive to vasoactive agent. Thank you for your attention.